Good afternoon, everybody. It's 1 o'clock. Let's begin. I'm Tanya Popovic, Director of CDC's Public Health Grand Rounds, and I welcome you, both those of you here and those watching us live. Here is some general information about CDC Grand Rounds and how to receive credits. This time, I'm going to dispense with any other information that I normally share because I want our speakers to have most time. All I want to do is just introduce them to you very briefly. So one of our speakers is actually Captain Kirk, who had the vision to think about emerging infectious diseases and lead the next generation of CDC and United States and global scientists, also known as Dr. James Hughes. Another speaker is Dr. Megan Hunt, also the star of the series Body of Proof, embodied in Dr. Ruth Linfield from Minnesota Department of Health. As you see, the entire list of speakers today is from the world of investigations and law, pathology, and similar things. The third speaker is Detective Bobby Goren from Law and Order, Criminal Intent, also known as Dr. Kurt Nolte from the University of Mexico School of Medicine. There remains the last speaker, and there is nothing more interesting or compelling about men than their eyes, so pay attention to the eyes of these men, light-colored eyes of Dr. House and CDC's Dr. Zaki. So while Dr. House has his own team, Public Health Dr. House obviously has his own team and has begged me not to forget to mention that nothing he does is by himself. He is, as I've mentioned today at lunch, the most annoyingly humble person at CDC. As many of you know, but some may not know, he's worldwide known for many of his contributions in detecting agents in tissues of people when we were not able to detect them using traditional or advanced microbiologic and other technologies. And here he's doing what he likes most, looking at the microscope and finding all these cool things. This photo was taken by me on October 7th in 2001. I just realized there's a typo, at 11:30 p.m. when he brought the tissues from first patient who died of anthrax from Florida in his own car and flew them from Florida when he did the autopsy. And here on the wall is a whole bunch of awards, among them 2 Shepherd Awards, and those of you who work on CDC, you know how sensitive I am about people who get a lot of Shepherd Awards. Never mind. And since I didn't know how to weave this in, I'm just going to be very blunt. I wanted you to sit back, relax, and enjoy the show, and I'm really shamelessly introducing the new generation of public health leaders, and this is my first grandchild, little baby Nora. And with that, Dr. Frieden is going to make a few introductory comments.
Explaining the unexplained and addressing infectious diseases is one of the core and fundamental aspects of public health. And as I've thought about the different kinds of challenges we continue to have, you might be able to summarize those in 4 broad categories. Something old, like flu or TB. Something new, like SARS or hantavirus. Something that borrowed a plasmid and became drug resistant, and something someone made that might turn you blue. But these basic concepts of long-standing diseases that are re-emerging or emerging in new places, new organisms that we're identifying at a rate of about 1 per year, the inexorable spread of drug resistance, which threatens to take us from the pre-antibiotic through the antibiotic to a post-antibiotic era for some organisms and patients, and the intentional or accidental release of organisms that have been created in a laboratory are four key areas that we have to deal with. Fortunately, we have very strong partnerships that enable us to deal with them effectively. We have state and local governments, we have international partners, we have academic partners, we have partners within the laboratory field and within medical examiners and medical investigator offices. So you'll hear about many of those partnerships in this session. Infectious diseases are always going to be with us. We are definitely outnumbered by microbes, but we don't have to be outsmarted by them. Thank you very much.
Thank you very much. It really is an honor and a pleasure to be here today to share briefly some reflections on recognition and response to emerging infectious diseases, and to celebrate the role that Sharif and his team played in defining a number of these emerging diseases. I want to take you back to 1992. It's amazing, it's 20 years ago now that the Institute of Medicine published this seminal report, Emerging Infections, Microbial Threats to Health in the United States. It was a team effort. The team was led by Dr. Joshua Lederberg and Dr. Robert Shope. It's important in many ways. First, it defined emerging infections as defined the concept as new, reemerging, or drug-resistant infections whose incidence in humans has increased in the past 2 decades, or whose incidence threatens to increase in the near future. A very broad definition, and one that specifically highlights the importance, even at that time, of drug resistance. The committee also identified 6 major factors that they felt were important in contributing to disease emergence and reemergence. They're shown here: human demographics and behavior, technology and industry, think of the food industry, economic development and changes in land use, international travel and commerce, microbial adaptation and change, which makes infectious diseases unique and particularly unpredictable, and then breakdown of public health measures as a result of the dreaded complacency that we see. I want to just highlight one of these, human demographics and behavior, and I'll do that in just one brief slide that shows a urban megacity environment. That picture on the left is from Dhaka, Bangladesh. In the upper right, a live animal or wet market in Southeast Asia, and on the bottom right, a contaminated surface water source in sub-Saharan Africa. Moving forward, the IOM revisited this issue in 2003 with another consensus study. The committee was again co-chaired by Dr. Lederberg, and this time he was joined by Dr. Peggy Hamburg, who's currently the FDA commissioner. They validated those 6 factors, and they added 7 more, shown here. And I will just highlight one of those: poverty and social inequality, the inequities that we encounter that are the root cause of many of the health problems we face around the world. Some photos to capture that: pre-earthquake Haiti in the upper left, a peri-urban slum in Mumbai in the lower left, and favelas in Rio on the right. There's a quote I wanted to share with you that's found in this consensus report. A robust public health system in its science, capacity, practice, and through its collaborations with clinical and veterinary medicine, academia, industry, and other public and private partners is the best defense against any microbial threat. Note that this quotation particularly highlights the One Health theme. CDC took these reports very seriously. In 1992, it got our attention initially, and then within 6 months after release of the report, we encountered the Jack-in-the-Box E. coli 0157 foodborne disease outbreak, the huge waterborne cryptosporidiosis outbreak in Milwaukee, and then the unexplained respiratory illness that turned out to be hantavirus pulmonary syndrome. A team led by Dr. Ruth Berkelman developed the initial CDC emerging infection strategy. That strategy was updated in 1998 by a team that was led by Dr. Sue Binder. In 2003, the follow-up IOM report came out. The timing of this one was not quite so good in that it was released 5 days after David Heyman at WHO in Geneva declared the first global public health alert related to SARS. So it did not get the attention on release that the previous report did. Now in this slide and the next, I've highlighted some of the outbreaks that occurred during the 12 years following release of the 92 report, starting with hantavirus pulmonary syndrome that you're going to hear a lot more about from subsequent speakers. What I've done here is circle some of the ones in which I spent a lot of time with Sharif and his team, who played important roles in sorting a number of these out. He'll tell you how they do some of that. But certainly hantavirus pulmonary syndrome, West Nile encephalitis in '99, and the anthrax attacks, and then SARS and monkeypox. A number of these resulted from cross-species transmission, so the zoonotic disease theme was a recurrent one. You see the hantavirus featured in the upper left, and some pictures of highlighting the SARS outbreak. In 1999, when West Nile was recognized in Queens, New York, for the first time in the Western Hemisphere, there was an op-ed in the New York Times that raised the question of whether this could have been a bioterrorism event. Fortunately, it wasn't, but 2 years later, as you all know, we faced a bioterrorism event. Sharif and his team played a critical role in this investigation. Tanya already alluded to one aspect. Here's another. A 38-year-old woman who worked for Tom Brokaw at NBC News in New York recalled getting a suspicious letter, developed this skin infection with this lesion. It took a while for the diagnosis to be suspected. You see the typical cutaneous anthrax lesion. Cultures were negative. A biopsy was obtained and sent to CDC. I got a phone call about 3 a.m. on October 12th from Dr. Zaki, who I was not anxious to hear from at that moment. I in turn called Jeff Copeland, then CDC director. He wasn't glad to hear from me either, but we met with Sharif at about 3:30 a.m. and looked at the immunohistochemical staining of the biopsy specimen, which clearly confirmed the diagnosis and the spread of the event to New York City. Now, speaking of global microbial threats, I wanted to just highlight SARS briefly. This is the critical event responsible for much of the global dissemination. This is a wonderful slide that was developed by Robin Mosley that illustrated what happened at the Hotel Metropole on the 9th floor, where there was a patient infected with this virus who stayed in his room for 24 hours, but somehow managed to transmit to more than 10 other guests at the hotel, who went on their various ways and introduced the virus into multiple hospitals in Hong Kong, to Vietnam, Singapore, the US, Ireland, and Canada, with devastating results. These events highlight the importance of state-of-the-art modern molecular methods in rapid diagnosis. And this is a slide that just illustrates some of the ones that are in current use or are coming along. These are important because of the potential to offer rapid diagnosis and increased sensitivity and specificity, but of course they have a cost and there are training needs associated with these. So, final slide, we need to continue to expect the unexpected, remain vigilant. I can't overemphasize the important role that over the years the alert physicians, the alert veterinarians, alert pathologists, alert laboratorians, alert researchers, and alert public health officials have played in initial recognition of these events. And you'll notice a couple of the headlines on the bottom to foreshadow some of what you'll hear about subsequently, and that's the role that transplantation has played in transmission of a number of these agents. So again, thanks very much for your attention. I look forward to subsequent speakers.
Thank you, Dr. Hughes. Good afternoon. I'm Sharif Zaki, Chief of the Infectious Disease Pathology Branch here at CDC. I'm really excited about this session because as far as I know, this is the first session dealing at Grand Rounds on pathology and public health. Let me tell you a little bit about what a pathology in a public health arena does. Pathologists are really among the first to encounter some of these infectious disease outbreaks and are in an excellent position to discover some of these diseases. The most exciting part of my job is really the ability or the opportunity to collaborate with top-notch scientists, both here at the agents, across the nation, and across the world. So the collaboration is really the key to these discovery of these diseases. Many of these diseases are being diagnosed through autopsies, which is really being recognized as an increasingly effective surveillance tool. So what's our approach here in our branch is what we see under the microscope, the histopathology, in the context of the clinical and epi features of a case or an outbreak to kind of direct us in terms of what kind of testing we do. We use a variety of techniques that you'll hear throughout these talks. Immunohistochemistry is one, or IHC is one that we use heavily in our branch. The first of these outbreaks I'd like to discuss in which used this approach is an outbreak back in 1993. These were previously, it occurred in the Four Corners areas in New Mexico. You'll hear later more from my colleague, Dr. Kurt Nolte, on the ground experience in New Mexico. But these patients were previously healthy young adults that were coming down with a flu-like illness and really a very high mortality. And the characteristic finding were these massive pleural effusions that were occurring, and you can see them here on the x-rays of these rapid progression of what we call whiteout of the lung. Now, a lot of testing was done both here at the CDC in New Mexico. For a lot of agents, nothing was really coming up positive, including things like plague and influenza. Now, there was a lot of fear and concern about this illness to the point of discouraging patients actually from entering to the clinics and actually asking them to stay in their cars and they will be examined there. So what was the first clue to this etiology of this outbreak? It really came from colleagues in the viral special pathogens branch here at CDC, Tom Kaisik and his colleagues, where they detected, and you can see here the first lab notes of this, what is ELISA is basically like a serology, but detecting antibodies to the known hantaviruses at the time. So it indicated that hantavirus could be the cause of this outbreak. But this was met with a real lot of skepticism at the time. Why the skepticism? Is because what we knew in 1993 about hantaviruses. We knew that they caused a renal disease, we knew that it caused a hemorrhagic disease, but not a pulmonary disease. That was number one. And secondly, we didn't know that any pathogenic forms existed in the United States. In fact, all of the experience with hantavirus illnesses was from Europe and Asia. So it really did not fit. So there again, that was the cause of skepticism. So we really needed some backup confirmation of hantavirus. And this came from two lines of investigations of tests actually developed here at CDC. I'll talk about the one that my team has been involved in was the immunohistochemistry. Immunohistochemistry is basically a technique where you use an antibody against a target bacteria, virus, whatever the pathogen is. If it recognizes it, it'll attach to it, and wherever it attaches, it will deposit a red color that we can see. So remember, we used an antibody that cross-reacted with all known hantaviruses. We were just kind of hoping that it would work, and it did work. Remember, these patients had a pulmonary leak. On the left here, you can see the pulmonary edema, the arrows pointing to the fluid in the patients of these lungs, but you can't see a virus there. You can see it on the right, and this is the first actually an original picture of the first immuno that was done, and you can see those tiny red specks, which are the virus depositing in the pulmonary microvasculature or capillaries. So that meant two very important things. Confirmed that hantavirus was the cause of the illness. Here it is in the diseased organ. And secondly, very importantly, remember the patients were leaking fluid in their lung. The hantavirus was responsible for that. It's basically poking holes in the vessels. And basically, if you have a pipe that's full of holes, you're going to get leaking, and you got leakage into the lung. Now, the very second, and then, and I actually say first, where the PCR test, which actually identified a novel hantavirus, was done in viral special pathogens with conserved fibers. And this shows you actually, again, a very historic gel. It was the first gel run on these patients. And you can see these bands across. Those were the bands that were a product, and then they were sequenced and showed it was a novel hantavirus, what we now know as Sinombre virus. So how did this help move the field? Let's talk about backwards. The big question at the time was this a new Black Death? Was it just going to spread like wildfire across the US? The simple answer was no. We went back to the archives to look at similar cases and found many cases that had occurred years before with the same diagnosis. We only had a new test. The earliest of these cases was back in '78. This is a picture of a young EIS officer, at that time Rick Goodman, who investigated an outbreak in Idaho close to a factory, and they thought the patient actually had died of a chemical injury. He was close to a plant. But the diagnosis then came 15 years later. But what happened that year was in 1993, there was a lot of rain, a lot of rodents, there was a lot of people investigating the disease, therefore the discovery of the disease that we now know. How do we move forwards? This was the map from '93, just showed one virus. It was a non-pathogenic virus here in the US. This is the map 20 or so years later. You can see the multitude of viruses here that have been since discovered. A lot of viruses that we know a lot more about this disease. Hantavirus pulmonary syndrome is big in the news these days, as a lot of you have heard. Yosemite Park situations, there have been about 9 cases, 3 deaths. At the bottom, you can see some of the pictures from those campsites. In the middle there shows you the rodent infestation with damage to those tents. So what happened in 2012? We obviously know about the disease. We can recognize it faster. We have better clinical management for patients and a better understanding of how the disease is transmitted. Natural reservoir, so you have better ways to prevent, control in terms of your community outreach measures. Now, the second outbreak I'd like to talk to you about happened just a few years later, 1995 in Nicaragua. This was hundreds of patients. They were coming down with a respiratory illness. This time they had pulmonary hemorrhage in their lungs as the main manifestation. Hundreds were being affected, and there were many patients that were dying. It actually got into hundreds. Now, because of the hemorrhage, as clinicians, as pathologists, we think about what was called viral hemorrhagic fevers. Therefore, a virus was suspected initially. And just a few days later, we got the specimens here at CDC. We looked at them. You can see here a picture on your left is the hemorrhage, the red blood cells in the alveoli. Those patients should be clear, but they're just full of blood. So that's the lungs of these patients. And the work we did here in developing a test showed actually that a bacterium was the cause of this disease, not a virus. What was the bacteria? The bacteria was the disease was leptospirosis. Leptospirosis is classically thought about when you see renal disease, liver disease, but that was relatively kind of a new association. We diagnosed it using, again, a novel test that we developed here, using a mixture of antibodies that would recognize these leptospires. And the big advantage is that clinically, if you want to culture the bacteria, it takes weeks, and it's very difficult. So that was a very rapid diagnosis to give to the etiology of this illness. And obviously saved a lot of lives in terms of prevention, treatment, et cetera. What do we know today about leptospirosis and this syndrome? This is now a classic syndrome. We think of it constantly. When we see pulmonary hemorrhage, pulmonary disease, we think of leptospirosis. Not only we think, across the world, think of this disease. Better recognize it. This obviously has a big role in terms of treatment, diagnosis, treatment, and saving lives. We know that it's associated with events in the atmosphere in terms of things like hurricanes, rainfall, etc. So we always keep a watch out when some of these events happen to see aftermath of these cases. In fact, during the surveillance of respiratory disease and during the pandemic flu, we uncovered actually cases here in the United States, the continental United States, that would have not been diagnosed otherwise. So the last thing I'd like to share with you is a little bit of our experience in the area of organ donation and transplantation. Now, the common thing here is the story is a single donor who unfortunately dies, but the good thing is they donate organs to recipients. The organs get transplanted. These recipients then develop a common illness that is suspected to be infections, and that's when we're called in to find out what's happening. Usually in routine hospitals, they can diagnose the common herpes or things that happen routinely will be diagnosed, but if they don't have it, then they'll call us to kind of try to see if we can come up with an answer. Now, these are very high-profile incidents. As you can see from these headlines here, whether it's rabies or LCMV or West Nile or amoebic transmissions, but the important is they raise a lot of questions in terms of safety of transplantations, or donor autopsies, things like what are the rules governing, and that's certainly changed a lot in the past 10 years. It's really a very rapidly progressing field. This is a list of some of the agents that we've identified or associated in the past 10 years with transplants. There are several, and there have been a lot of different outbreaks, and some of them, even like LCMV, we only recognized it once, but there have been about 6 clusters of that disease since then. Now, the last thing I'm just going to leave you is with the first of these investigations back in 2002. It starts with a young female who was involved in a car accident, received multiple transfusions. Unfortunately, she did not survive, ended up as an organ donor, and all the recipients who received organs from her then developed a fever. One of the patients, actually a kidney recipient who died actually next door here at Emory Hospital, died of an encephalitis. And we went down and did the autopsy there. And this patient was, because it was in 2002, just after West Nile, West Nile was thought to be the cause, but serology testing was negative. So we were started off with a negative, but we still tested for West Nile. This is an immunohistochemistry of the brain of that patient, and these are neurons that are red in color. These are the brain was just full of the viral antigens. So it showed that the association that these diseases were really being caused by West Nile. And it really was the start of the traceback. A lot of folks here in the audience and laboratorians, epidemiologists went back and traced a lot of these blood products that were given. She had received the accident victim 63 donor supplies. So some of them, and notice Martha's here, and they were recognized as that some of those were actually had the West Nile. The patient was not West Nile positive when she first entered the hospital, but because of the transfusion, she got enough virus then that she was then transmitted on to recipients. Now, I'm just going to conclude here, and hopefully that showed you some of the increased awareness of these emerging diseases. And really the fundamental approach is the multidisciplinary, both traditional methods like culture or serology, and some more the state-of-the-art PCR or others. And it's the collaborations, which I emphasized before. And hopefully, as a pathologist, I've showed you the front line of pathology and recognizes these diseases and guiding some of the epidemiologic investigations. And again, the important message is autopsies as a surveillance role that you'll hear more from our next two speakers. First, Dr. Nolte. Thank you.
Good afternoon. I'm Dr. Kurt Nolte, a forensic pathologist from the New Mexico Office of the Medical Investigator, which is the statewide centralized medical examiner agency for New Mexico that's academically based at the University of New Mexico School of Medicine. And this afternoon, I'd like to talk to you about MedX, a medical examiner surveillance model for infectious disease mortality. But first, I'd like to start by telling you the beginning of a story that you first heard about from Dr. Zaki. So this story starts on May 14th, 1993, when a young man from the community of Little Water, New Mexico, on the Navajo Reservation in the Four Corners region, died en route to his fiancee's funeral. And his death was investigated by Mr. Richard Malone, a field investigator for our office, who learned that the young man had been ill for several days with flu-like symptoms and then had developed the abrupt onset of shortness of breath. But what really startled Mr. Malone was when he learned that the decedent's fiancée had died of identical symptoms. He got on the phone immediately to the on-call forensic pathologist, Dr. Patricia McFeely, who was very worried that both of these individuals might have plague. And she requested that both decedents be sent to Albuquerque for immediate nighttime autopsies, which is a very unusual situation in forensic pathology. And Mr. Malone had the task of going to the fiance's family and requesting that they stop the funeral so that the body could be sent in for autopsy. Dr. McFeely performed both of those autopsies and was struck by the similarity in the findings between the cases, namely large accumulations of fluid in the chest cavities and a large amount of fluid in the lungs. And she was also struck by the similarity to a decedent she had autopsied 1 month earlier and had been puzzling over from that time forward. So that evening, she got on the phone to the New Mexico Department of Health and reported a cluster of fatal respiratory disease deaths in the northwestern part of the state. 3 days later, Indian Health Service physicians reported a cluster of 5 deaths, including the 3 cases from OMI. And from that point forward, there was a very rapid, multi-agency, multidisciplinary investigation that culminated approximately 2.5 weeks later with the recognition of, or the detection of, hantavirus antibodies in 3 of the decedents by CDC, and what is now known as hantavirus pulmonary syndrome came into being. So why did I tell you this story? I told you the story to demonstrate that the medical legal death investigative system can be a critical element in recognizing fatal emerging infections and infections of public health importance. But there is a popular misconception, I think, amongst most of the public that forensic pathologists handle largely homicides. And in fact, about half of the autopsies we perform are in individuals who have died of natural causes. And if you look at this group of individuals, about a quarter of those individuals have died from infectious diseases. So I'm here today to talk to you about autopsy-based surveillance, and I thought it might be useful to talk about some of the advantages of autopsies over death certificates, which are useful for demonstrating trends over time. But autopsies allow you access to human tissues, and access to human tissues permits enhanced diagnostic capacity.
And with those diagnoses, you can make a more accurate determination of a cause of death. You can gain insights into the pathogenesis of a disease. For example, with hantavirus pulmonary syndrome, we knew that it was a capillary leak process. You can gain insights into the route of an infection, as Dr. Zaki's work with inhalational anthrax has demonstrated. And with autopsies, you can have more rapid notification of public health authorities of the findings than with death certificates, which have to be filed and coded and amalgamated and released. And certainly more infections can be recognized at autopsy than are encoded by death certificates. For example, an individual can die of a gunshot wound of the head. That's the cause of death. But they might have active pulmonary tuberculosis, and that's not on a death certificate. So I'd like to tell you now about MedX surveillance. With funding from the CDC Bioterrorism Preparedness and Response Program in the New Mexico Department of Health, the New Mexico Office of the Medical Investigator created a medical examiner syndromic surveillance model designed to recognize bioterrorism in the broader context of providing capacity to recognize fatalities from infections of public health importance. The model is based on a set of symptoms to recognize potential cases, drive decisions about autopsy performance, and a set of autopsy-based syndromes for the early reporting of cases to the Department of Health. Both the symptoms and the syndromes are derived from most of the known bioterrorism illnesses. The case evaluation process includes an attempt to make an organism-specific diagnosis in all infectious disease deaths. And for this purpose, we received valuable assistance from Dr. Zaki's lab for advanced laboratory diagnoses such as immunohistochemistry and PCR. So this is the list of symptoms that we use to determine whether a jurisdictional case received an autopsy. For example, flu-like symptoms, fever or chills or muscle aches. At the bottom you see unexpected death, which might seem unusual as a symptom, but it's a phenomenon that's not uncommon. And for the purposes of this study, it was defined as the death of an individual less than 50 years of age where the circumstances, past medical history, and scene investigation provided inadequate diagnostic insight to establish the cause of death. This is one of the 11 autopsy-based pathologic syndromes: community-acquired pneumonia, acute respiratory distress syndrome. All of the 11 syndromes are linked to bioterrorism-related illnesses and to infections of public health importance. So on this slide, while an individual with this syndrome might have plague or tularemia, it's much more likely that they'll have influenza, pneumococcal disease, or a variety of other infections. So what did we learn in 2 years of testing this surveillance model? We examined over 6,000 jurisdictional cases, of which 250, or about 4%, met entry criteria into the study. A little more than half had a pathologic syndrome and slightly fewer had an infectious disease. And of the infectious disease deaths, we made an organism-specific diagnosis in 81% of the cases, which runs contrary to the popular dogma about this capacity in autopsy pathology. And of the cases where we identified the pathogen, about 60% were notifiable conditions by New Mexico public health standards, largely invasive streptococcal pneumonia infections. We evaluated the positive predictive value of the MedX symptoms. So given you're dead, given you fall under medical examiner jurisdiction, and you had flu-like symptoms before you died, you have a 65% chance of having an infectious disease at autopsy. Fever and respiratory symptoms, a 72% chance. Unexpected death, only 19%. New-onset encephalopathy or seizures, 50%. So what did we conclude? Well, flu-like symptoms, fever and respiratory symptoms, and encephalopathy or new-onset seizures are highly predictive of infectious causes of death, and they make useful criteria to perform autopsies to recognize these conditions. Sudden unexpected death much less likely to represent an infection. Organism-specific diagnoses can be attained in the majority of infectious disease deaths and are dependent on the pathologist making the effort to obtain and test the appropriate specimens. Uniform autopsy and reporting criteria increase the recognition of public health conditions, and we believe thereby increase the likelihood of recognizing bioterrorism-related deaths. But because infection or deaths from bioterrorism are rare and fatal infections of public health importance are common, combined surveillance systems really serve the public good and can be tested, modified, and utilized daily. MedX is currently used in about 13% of large medical examiner coroner offices in the US, serving a population of about 15 million. It's also being used by 2 of the 4 states in the CDC Unexplained Death from Infectious Diseases program, and Dr. Linfield will be telling you about the Minnesota experience with this program shortly. So what's required to implement MedX? Well, a uniform area of medical legal death investigation. Jurisdiction is needed that's linked to a health department that shares the same jurisdiction. You need a uniform investigation of jurisdictional deaths. Forensic pathologists need access to a microbiology laboratory, and they need an electronic data management system. I'd like to conclude with a slide that has the text that's a translation of a Latin mosaic from the wall of the New York City Medical Examiner's office. It reads, "Let conversation cease, let laughter flee, for this is the place where death delights to help the living." By identifying infectious disease deaths, medical examiners contribute valuable information that can be used to improve the health of the public. Thank you for your attention. The next speaker will be Dr. Ruth Linfield.
Good afternoon. It's truly an honor to be here. I am Ruth Linfield, State Epidemiologist and Medical Director of the Minnesota Department of Health. I will discuss surveillance for unexplained death in Minnesota and talk about the history of this surveillance, findings, how the findings have informed public health action, and the general challenges and benefits associated with this surveillance. In 1995, the surveillance for unexplained death, or UNEX, began as part of the CDC Emerging Infections Program in Minnesota, Connecticut, California, and Oregon. The goals of this project were to identify novel and newly emerging pathogens, identify deaths due to known pathogens that present as sudden unexplained deaths, to monitor the epidemiologic features of fatal infections, and to improve pathology-based diagnostic testing. In Minnesota, in addition to death, we have included critical illness in the surveillance. Our case definition is a death or critical illness unexplained by routine testing that has pre- and or post-mortem findings suggestive of infectious etiology, such as fever, leukocytosis, cerebrospinal fluid pleocytosis, or histopathological evidence of an infection. Our focus for this surveillance is on persons who were previously healthy and under 50 years of age, but it is not limited to this population. UNEX cases are reported to MDH by clinical partners, including those at acute care facilities such as infectious disease physicians, infection preventionists, and hospital pathologists. Our main reporter outside of acute care facilities are medical examiners. Information is collected from medical records, scene investigation findings, autopsy and pathology reports, and are reviewed by MDH UNEX staff. Specimens are sent to MDH and tested at MDH and at the Infectious Disease Pathology branch at CDC. Testing results are correlated with pathologic and clinical findings to determine the cause of death. This figure shows the case numbers and breakdown by syndrome for unexplained deaths and critical illnesses from 1995 to 2005. Note the increased numbers of cases over time. Respiratory cases was the most common syndrome in most years. In 2006, we initiated surveillance for all fatal infectious diseases in selected medical examiner jurisdictions. This surveillance is known as MEDEX. We began with the Minnesota Regional ME Office, which covers 8 counties and 14% of the Minnesota population, and have continued to conduct active surveillance for infectious disease deaths through review of their cases. During 2006 to 2011, an average rate of 12 infectious deaths per 100,000 population was found. We've expanded MEDEX to include the other medical examiner jurisdictions in Minnesota. MDH provides specimen collection materials such as swabs and viral transport media, with specimens being sent to MDH for testing. We have based our MEDEX surveillance on the New Mexico MEDEX model. From 2006 to 2011, there were 1,520 cases reported to MDH. 347 were determined to be non-infectious, and 74 others did not meet criteria for MEDEX or UNEX. There were 723 UNEX cases, 908 MEDEX cases, and 532 that fit both UNEX and MEDEX criteria. Among UNEX cases, there were 298 UNEX cases that were persons less than 50 years of age, previously healthy, and had specimens available for testing. These included 70 critical illnesses and 228 deaths, and I will refer to this group as the UNEX subgroup. In all 3 groups, males predominated. Median ages were 48 among MEDEX cases, 42 in the UNEX cases, and 13 among the UNEX subcases. The median age of fatal cases in the UNEX subcategory was 9 years, and the median age for critically ill cases was 17 years. Let's look at the MEDEX cases between 2006 and 2011 by syndrome. The number of cases increased over time as MEDEX expanded to include additional ME jurisdictions. The large number of respiratory deaths were increasing in 2009 during the influenza pandemic, when enhanced surveillance for deaths due to influenza-like illness was initiated among MEs. This surveillance detected cases of pandemic influenza and other respiratory viruses and enhanced the ME's interest in submitting cases. There was also an increase in the number of sudden deaths evident from 2009 onward. These include sudden unexplained infant deaths, which I will discuss later. These are the UNEX cases in the subcategory of those persons under 50 years and previously healthy that had specimens available for testing. Note the large number of respiratory cases in 2009 to 2010, coincident with enhanced surveillance for cases of critical illness and death due to an infectious respiratory syndrome during the influenza pandemic. Here's a breakdown of the definite and probable explained cases during 2006 to 2011 by syndrome. Overall, 29% of cases that had a specimen available for testing was explained. 36% of the UNEX and the UNEX subgroup were explained. Cases with the respiratory syndrome were most commonly explained, with a little more than half in the UNEX and UNEX subgroup explained. And sepsis or shock was the next most commonly explained syndrome. This chart shows the methods of diagnosis in explained UNEX subgroup cases. Note that most pathogens were detected by PCR, including Pathogen-specific and 16S PCR. However, culture and other techniques such as immunohistochemistry were very useful. An area of interest of ours is infectious etiologies in sudden unexplained infant deaths. Overall, 32% of sudden unexplained infant deaths with infectious etiology were explained during the 2006 to 2011 period. By syndrome, respiratory and cardiac were most likely to be explained. Some pathogens detected include respiratory syncytial virus for respiratory and Coxsackie virus for cardiac. The identification of pathogens found in UNEX can result in public health action. Some pathogens require specific public health interventions, such as Neisseria meningitidis, vaccine-derived poliovirus, and tuberculosis. For vaccine-preventable diseases, such as Streptococcus pneumoniae or influenza, getting a truer estimate of the burden is useful, as these cases would not be identified through other surveillance systems and represent the most severe cases. Some pathogens, such as HIV and Legionella, are nationally notifiable. We have detected infections that were new to Minnesota, including Rickettsia rickettsii, Powassan virus, and Naegleria fowleri. This surveillance allowed us to find diseases that we had not known could be acquired in Minnesota. That enabled us to educate clinicians and the general public in methods of prevention, diagnosis, and treatment. For Rocky Mountain spotted fever, one of our fatal cases had no travel history. Ticks were collected and found to carry Rickettsia rickettsii. We educate physicians that Rocky Mountain spotted fever may indeed occur in Minnesota. We detected our first case of Powassan encephalitis in a critically ill child in 2008, and subsequently asked clinicians to send us specimens from potential cases. Between 2009 to 2011, 14 other cases were detected. In 2010, a case of primary amoebic meningitis was confirmed through UNEX. This was the northernmost case of Naegleria fowleri reported. We educated clinicians and the public about the disease. Unfortunately, we had a second case diagnosed in 2012. During the H1N1 pandemic, we established enhanced surveillance for deaths due to influenza-like illness through the UNEX and MEDEX systems. Specimens were evaluated from cases with influenza-like illness based on pre-mortem symptoms and/or autopsy findings and laboratory testing. We also had laboratory surveillance for confirmed H1N1 influenza in hospitalized patients with ILI. We reviewed medical records and other data to determine if H1N1 was related to the cause of death. 66 deaths were found, and 16 cases were found through the UNEX-MEDEX system. Interestingly, cases from UNEX-MEDEX were younger, less likely to have underlying conditions, and more likely to be non-white. I would like to conclude with a few thoughts about what we have learned from conducting UNEX surveillance. The main lesson is that partnering with medical examiners and pathologists to conduct infectious disease investigation and testing is especially important in identifying fatal infectious disease cases. Case-based death investigation is unique in correlating laboratory findings, clinical features, and pathological evidence to establish a causal relationship. Cases of infectious disease of public health importance are detected that otherwise would likely be missed. One of the challenges is that sometimes potential pathogens are identified, but these may not be the cause of the syndrome or death. In addition, this type of surveillance is resource intensive for medical examiners, pathologists, and public health staff. And additional testing and materials are required for both the MEs and pathologists and the public health laboratories. However, we have found it to be very useful, especially in investigations of emerging pathogens. And I would like to conclude with a few thoughts. As you have heard from our speakers, emerging and re-emerging diseases are well and alive. Critical components for their detection, prevention, and control include vigilance and broad partnerships, a multidisciplinary approach, and advanced diagnostic tools. Thank you very much.
I'd like to thank all our speakers and the audience for your attention. Open this session to questions. If you have any, please come up to the microphone on either side and state your name, please. Rana.
Yes, thank you all very much. This is Rana Hajji with the Division of Bacterial Diseases and NCI-RD. This definitely brings back a lot of memories of the initial unexplained death syndrome. Before I start, I just have to make one comment to Tanya. Of all the characters you chose, I think the most unfair is for Sharif, because he's definitely nicer than Dr. House. I have to say that. Just a few comments. As Ruth mentioned, I mean, the initial unexplained death syndrome is one that I'm quite familiar with since we set it up, and I was surprised to see that the proportion of explained, for example, for the respiratory cases, hasn't changed much since the initial results of the pilot project from the first 4 years were initially reported. So maybe it's still about 1/3 of the unexplained severe cases are explained. And I'm wondering if this is still a function of the, of the quality of the specimens you get, how fast you get them, or is it like, do we really still need to do a lot more with regards to the diagnostics? So that's one question. Would appreciate your comments. Then the other thing, if either Dr. Nolte or Sharif can comment. I remember with Unexplained, one of the problems with autopsies that we used to have quite a low rate. I was actually surprised, not being a pathologist, how low the rate of autopsies was in the US overall. Has this improved? Are we doing better, encouraging more autopsies across the US? And then just as a kind of finishing comment, I was hoping that we move on soon. I mean, I think it's great to use autopsies as surveillance tools for severe disease, but since especially you said that many of those are not actually fast death. I mean, can we use biopsies hopefully and try to prevent death if we can? Thank you.
So I'll give a few comments on the first part. Actually, we've done a lot better since the first years. I think with the addition of immunohistochemistry a number of years ago, that really increased the number of explained deaths, particularly for Streptococcus pneumoniae. And then the ability to be able to do PCR has been tremendous, to be able to do that on tissue. It is a problem of getting the correct specimens. It's much easier to do PCR on fresh or frozen tissue than on tissue that has been fixed. Certainly, I think as we gain more in diagnostic methodology, we'll do better. But I think having the tools at our disposal now, if we can get the right specimens, I think that we very often can make a diagnosis.
Let me handle the second part of your question, but I'd like to just add with the answer that certainly in infectious disease deaths, microbiologic culture is the cornerstone. And in the MedX project, 80% of the organism-specific diagnoses are made through post-mortem microbiologic culture, 10% from anti-mortem microbiologic cultures that send out the results after the deceased died, and 10% from reference laboratory techniques such as PCR. So your second question was about autopsy. And autopsy comes in two varieties in the U.S. Hospital-based autopsies, which are done with the consent of the deceased next of kin, and the other variety is, I'm sorry, I had to take my finger off. Now you really can hear me. The second type are medical legal autopsies done without the decedent's or the family's consent, but authorized by state statute. Hospital-based autopsy rates are in single digits nationally. The last stronghold of autopsy performance is forensic pathology. Probably close to 98% of all the autopsies performed in New Mexico are performed in our office, despite the fact that only a minority of the deaths fall under our jurisdiction. So really, the hospital autopsy is vanishing. You asked whether more limited procedures such as biopsy might be a way of countering some of these diminishing autopsy rates. Unfortunately, limited autopsies yield limited information, right? I mean, if you only go in and examine the lungs, but the condition mostly affects the kidneys, you're not going to get an answer. And an autopsy is a systematic examination of a dead body, examining all of the organs. So not only do you have to target the correct organ with a biopsy, you have to target the correct region of the organ. So biopsies might be useful at times, especially when families do not consent to a full autopsy and they're only willing to allow a limited procedure, but really full autopsy is the way to get full information.
We're running out of time, but we could have time for a quick question. Tweet.
Thank you. We have several questions from our Facebook and Twitter followers. A lot of interest in Naegleria fowleri, specifically, what is the status of a rapid detection test?
Rapid detection tests for Naegleria are
Yes.
basically PCR, if you have a patient sample, or actually visualizing in the, so actually visualizing in the tissue or a CSF or a PCR. And natural sources, you know, again, you can usually need to culture, so it may take a day or two. Dr. Schoenberg?
Yes. As people here know, I'm in charge of the prion disease surveillance, which is very heavily dependent upon pathology. And I'd like to congratulate and reinforce the importance of the pathologist in infectious disease surveillance. You mentioned, Dr. Nolte, I guess, that there was a difference between death certificates and pathology, some of the advantages of each. We use death certificates, and I think majority of people who are applying surveillance techniques will use death certificates over autopsies for the very reason that you talked about, that autopsies are so rare and death certificates are required from every death. And the question I would have is how to connect those two a little bit better so we can take more advantage of the work of the pathologist so that they can connect their results with the death certificates. And that's one of the projects that we're currently trying to do now in the prion disease surveillance, where we have a very good system now for pathology, which we've had to develop over time to overcome what you've heard as single-digit rates of autopsies. We're now way up for this specific disease. But to take advantage of the results of that pathology, you need to try to hook it up with the results of death certificates. And I think that that's an area that the group should address for improving surveillance in general. Take more full advantage of the results of the pathologist's work.
So that's an excellent question, and that's quite a challenge. And so a death certificate might read cause of death dementia, and then the person's brain might be sent for pathologic examination, and 2 months later a diagnosis might come out of Alzheimer's disease or multi-infarct dementia or Creutzfeldt-Jakob disease. And that information is supposed to feed back into the death certificate. Death certificates are not set in stone. and they can be easily amended, and they're supposed to be amended. However, they're frequently not amended, and that is a dropped step in the chain, and pathologists can amend them, hospital pathologists can amend them, forensic pathologists frequently amend them. We're the physicians who are probably the most familiar with death certification. We generate the highest fraction of death certificates among physicians, and we amend them frequently. You probably are aware that whether or not an autopsy is performed is one of the variables on the death certificate, and it is in fact coded by the National Center for Health Statistics. And so you can search for data, causes of death that have autopsies performed if you want to identify a subset of cases that have autopsy validation.
I'm afraid we're out of time, but if there are any questions after, be happy to get them. Thank you very much.
Thank you very much. We did take a little bit longer with our presentations, but they were really fabulous, so we had a little bit less time for discussions. Thank you for staying longer. See you next month. Thank you.